Hey folks, in today's episode we are going to continue the research theme from the last few weeks. We're going to dive into why studies, particularly in critical care, ultimately fail. We will talk about the use of mortality as an outcomes variable, the use of composite outcomes, and the scarcely talked about topic affectionately known as the Fragility Index. Joining me to discuss these topics is former Brown faculty member Dr. Eric Benoit. After finishing his general surgery residency at Tufts Medical Center, Eric came to Brown to complete his fellowship in surgical critical care. He then stayed on with us as a faculty member for a number of years before heading back to good old Massachusetts last year, where he is currently an assistant professor of surgery at Tufts University School of Medicine and part of the Trauma ACS Surgical Critical Care faculty at Lahey Hospital and Medical Center. Eric has a particular interest in clinical trial design, and I thought he would be great to have on with us today to discuss this topic. I'd like to welcome Dr. Benoit to the podcast today.
Hey, Ken, how are you?
I'm well. Thank you again for joining us. Jumping right into things, there's always a lot of talk about research trial design in medicine. We were all taught that the randomized, double-blind, placebo-controlled trials are the gold standard. Despite the meticulous planning that goes into these trials, however, they are not always successful. This is especially the case in critical care trials where the majority of studies are unable to show a clear benefit, particularly around survival. So my first question to you, Dr. Benoit, is why is this? Why do you think studies fail?
Well, first off, thanks, Ken, for the invitation, and it's nice to be back, even though remotely, and be talking with you about these things again. So the question of why do trials fail is a big one, and as you say, we're taught that randomized controlled trials, RCTs, are the gold standard in trying to evaluate novel therapies, but particularly in the critical care environment. Most trials do not succeed. Most trials fail to show a mortality benefit. And I think that many of us assume that trials fail because the intervention being evaluated doesn't work. And so that's kind of the take home is that, steroids and septic shock, paper X says they don't work, okay, because they failed to achieve a statistical significance and decrease in mortality. Therefore, steroids don't work. And then you throw everything out. And that's certainly a reason why an intervention, why a trial may fail, because the intervention doesn't work. But there are other things that come into play. And, a big part of that is trials may be underpowered. And therefore, statistically, they don't achieve their endpoint. And so what comes into, what drives underpowered trials? Well, you need events. You need a number of events in a trial so you can detect a difference between the control group and the treatment group. So if your event rate is too low, you just don't have the number of events to distinguish a difference between one group and another. So that's a big thing that I've looked at. The other thing is that you may have an inappropriate treatment effect. So the intervention may work, but when you design the trial, you may make the assumption that your treatment is going to work very well. You're going to reduce mortality from 50% to 25%. I think what I have seen and others have seen is that the treatment effect is often overestimated in the planning phase. And if you do that, you build your trial around this treatment effect that's going to make a big difference between your control group and your treatment group. If you overestimate that, you're going to have a trial which is too small. Then you have an insufficient number of events, and then you can't tell the difference between those two things.
Yeah, and I was going to ask you this later on, but can you elaborate on the treatment effect for the audience? What is that number specifically, and how is it calculated?
Yeah, and so the treatment effect, and we'll use mortality as an example because it's an easier one to look at. So that's the absolute reduction in mortality between your control group and your experimental group. So it's the absolute difference in outcome between your two groups. So that's the treatment effect, and usually that's expressed as a percentage. So, like I said, if in your control group you estimate that you're going to have your mortality is 50%, and then in your treatment group you estimate that your intervention is going to do such a good job that your treatment group is going to have a mortality of 25%, you cut that mortality in half. So then your treatment effect in that case is 50%. So if you have a larger difference or a larger treatment effect, you don't need as many patients to detect a difference between the two groups. And so this is something that others have looked at in critical care trials. There's a nice paper from a couple of years ago. I think the author is Harhay. He looked at a whole series of critical care papers and found that I think there was only one trial where the treatment effect was underestimated. So most people overestimate that number. When I looked at the randomized controlled trials in trauma, every single trial overestimated what the treatment effect would be. So, the big question is, the question is why. I don't have an answer for that. I mean, although it makes sense that these kind of trials they demand a lot in terms of resources and time and energy, and they demand, particularly at the outset, somebody who believes in the intervention. So if you really believe in the intervention, you're passionate about it, you think you're optimistic, and so you think, well, this is what's going to happen. I think that's the charitable view. The cynical view is, and this may be true also, is that you figure out what are the tolerances, how many patients do you realistically think that you can enroll. So this is my sample size because this is what I have funding for, time for, whatever. And then you kind of back analyze it and come up with what your treatment effect is going to be. The big problem for all this is you can't really go anywhere to find the treatment effect. There's no book where you go to and say, so, doing balanced resuscitation, blood product resuscitation versus, unbalanced resuscitation, what effect do we think that's going to have on mortality? You can't do that until there's an initial trial. And so that number, to a certain extent, comes out of thin air. And one of the things that I've seen in doing a lot of reading on this, and you probably remember this from sitting in Friday morning conferences and we talk about papers, those numbers are by necessity derived from small trials. And for those trials that actually document where that information comes from, you'll see a difference where, the treatment effect is drawn from a single center study that was maybe published in 2001, which is then used to help drive the design phase of a study that begins enrolling patients by maybe 2005 or 6, and they're done enrolling by 2008, and by the time that paper gets published, it's another couple of years. So the difference you're looking at from the time of the initial study to time of publication, maybe it's 10 years. I mean, we see that a lot. And there's a lot of change that may happen in the standard of care, which then dilutes out what the treatment effect may be.
Yeah, I'm glad you said that. I think that's a good point to emphasize. When we talk about why trials fail today, I think it's important to recognize that the standard of care ultimately changes over time. And this may be one of the downfalls, among others, maybe of the Manny Rivers trial and early goal-directed therapy. I think it was fairly novel at the time to resuscitate patients so aggressively up front. And now you can say what you want about that particular paper, but it ultimately changed our culture, specifically in critical care. Our current standard of care recognizes that you resuscitate patients up front with 30 cc's per kilogram for those identified as being septic. I don't think you could ever attempt to pull off a study like that today around resuscitation efforts because of where we are with standard of care.
So that paper was published in 2001. It's a single center study. There's a 200 some odd patients, and it's a single center study means that you have somebody who can focus in on, hone in, and control a lot of the variables. So after that, that study was practice changing, right? But then in 14 and 15, there were 3 other studies that were done, Process, Arise, and Promise, I think, all with almost identical protocols, all of which basically wanted to answer the question, does early goal-directed therapy for sepsis work? And they, what they found was that it didn't. Basically, they didn't show a statistically significant difference in mortality. However, if you start looking at what happened in those trials, you have, Manny Rivers single center study with a couple hundred patients. You have 3 multi-center, multinational studies with over 4,000 patients, but those things are done over 10 years later, and the baseline mortality rate drops significantly. In the Rivers trial, it was over 50%. And think about that. Patients who are septic with over 50% mortality is incredibly high. By the time you get to the other studies, their mortality, is somewhere in the mid 20s. So the problem there is it's not that early goal directed therapy doesn't necessarily work. It's that it sort of gets adapted, and then other things make a difference. Other things, the standard of care improves. This is kind of the what's described as the paradox of progress. There's a really nice paper, I think in JAMA, by an author named Kent, where he's got a figure which shows that as mortality decreases, it becomes exponentially more expensive in terms of resources, money, time, whatever, to show marginal improvements in outcomes. So basically, if we've picked all the low-hanging fruit, it takes more. It takes more in resources to climb higher up the tree, and part of it is, and part of the reason is, as we improve, the number of events goes down, and so there's an author named Sackett who wrote this kind of interesting paper. It's like 20 years old, but he talks about what matters is not the number of patients in a trial, but it's the number of events in a trial, because that's really what you need to show a difference. And as we get better at what we do, it's harder to show a difference to say, all right, we can get even better. Because when you initially, the question you started out with at the beginning is, look at the literature in critical care, particularly. All of these trials show that we can't. All these trials fail. Does that mean that we're not getting any better? Does that mean that we're not making a difference? Well, I'd like to say we're biased, right? But I'd like to say that we do make a difference. But it's a lot harder to show that for novel therapies, because all kinds of things make a difference.
Yes, I completely agree. And, you mentioned it a few times now. Why do these studies keep using mortality as a primary outcomes variable? I mean, should we even be looking at that variable in research trials, particularly in critical care, where we know going in that the mortality rate is going to be significant just based on the population of patients we're taking care of? I mean, is it even feasible to think we can alter mortality rates with some of these proposed interventions?
So, mortality is a difficult endpoint for a lot of reasons. But why is it a good endpoint? It's easy to measure, right? As they say in the military kind of stuff, it's legs up or legs down, right? Like there's no subtlety, there's no ambiguity, and particularly for all-cause mortality, you don't need to adjudicate it. It is an outcome which ostensibly is of interest to the patient, and it's because it's easily measured. There are certain, the FDA will mandate that mortality is something that we need to look at.
Yeah, not to interrupt you, but I think that's a really important point. People don't realize that regulatory agencies do have a say in trial design. They're going to be less apt to approve new therapies, especially in critical care, unless you can show them some baseline data that your study has the potential to improve mortality rates in this patient population.
Yeah, it's interesting. In sort of a past life, when I was doing some consulting on this stuff, and which kind of initially drove my interest in this, I was working on a trial, and we were going to the FDA, and the endpoint was the sponsors wanted the endpoint to be something, and the FDA said, well, no, mortality needs to be a component. It was a vascular surgery trial, so we were looking at, they mandated it to be amputation-free survival, which is a composite endpoint and everything. But it was interesting because a couple of the investigators said, well, that's not fair. Like we want it to be, amputation, because we think our interventions can change that. But the reality is you have to play the game by the rules of the people who designed the game, right? So if the FDA says we got to look at mortality, you got to look at mortality. So, and mortality is funny, right? Because it will tell you whether a therapy is effective, but there's also a safety component to it. So, in reviewing the RCTs in trauma, there's at least one trial where the interventional therapy increased the mortality rate. This is one of the artificial blood substitutes. And part of it is because the intervention seemed that it was actually dangerous. So mortality is an efficacy endpoint and a safety endpoint. On the one hand, you say, well, that's great, right? Bang for your buck. The problem is then that it's actually a very coarse endpoint. And now we're kind of segueing into why is it not a good endpoint? If, like, you may have patients where the signal is very strong. There are patients who may benefit. Treatment X may actually improve mortality. But for certain patients, it may not be beneficial, and more of those people may die. But if you're looking at all-cause mortality, you're kind of mixing them all up as one. You're sort of missing the signal for the noise. So the signal is kind of the difference in effect between the control and the treatment group, right? We want to maximize that. We want to decrease the uncertainty, the variability, the noise. Mortality is really messy that way. So it's a really coarse endpoint. So I think that's one of the biggest problems with mortality.
Are we shooting ourselves in the foot by using it, you think?
So, I mean, that's why when I've given this talk in various forums, the snappy subtitle or title is, we have a problem with death, because, yeah, I mean, I think we are, but the caveat I would offer is there's no perfect endpoint. It's like, what's the perfect way what's the perfect measure of adequate resuscitation in our patients? Well, I don't know. Do you want to use lactate? Do you want to use CVP? Well, you have to know what the pitfalls are for any of them. So, I hew to mortality is a useful endpoint. It's, but you have to know what its failings are. That being said, the more I read about it, I think it's too coarse of an endpoint, or we have to do a better job at selecting patients. So patient selection. So I view trial, the design part as, there's the patient selection, there's what's the control event rate, so what's the mortality rate, so how many number of these events are we going to have, and what's the treatment effect, and they all kind of play together. So patient selection is important because the risk of whatever your outcome is, and so your risk of mortality, is not linearly distributed, or not even evenly distributed among your population. So we have patients who are going to die regardless of what we do. We have patients who are going to survive regardless of what we do, but then there's a small subset of patients who we can affect their outcome based on our interventions. So, like the 18-year-old kid with appendicitis, he's not going to die, right? We can do all kinds of awful things and, lose the car keys in the abdomen, and that person's probably not going to die. So, like, mortality is not a good endpoint for that. You can have, a 95-year-old with COPD and heart disease and, pelvic fractures and, bowel perforation. We're not going to salvage that person. So that person, like, we can't intervene on. The world where you and I live in critical care is that middle ground of who can we influence, who can we affect, and not only who do we affect with an intervention, but who do we then rescue from the complications that inevitably are going to happen in this kind of a population. So the challenge is we need to select a patient population. We need to kind of enrich the population in a study that's going to have more events. But we can't, particularly for mortality, they can't be such a high-risk population that the intervention is not going to make a difference whatsoever. And that is exceedingly hard in critical care. It's almost, I don't want to say impossible, but it's really hard in trauma because, these patients come in basically in the door. You don't have a therapeutic relationship with them. And so it's really hard to stratify and things like that. But this is where the question of stratifying patients into various risk profiles work, stratified by age and renal failure and ISS or what have you. That's what we're trying to do when you stratify, is to look at these patient populations. A big problem, though, and I think we talk about stratification in terms of subgroup analysis. I am one of those people who says, I don't really care about subgroup analysis, because if you cannot reach your primary endpoint, the rest of it doesn't matter. The rest of it is hypothesis generating at best. But, you read these papers and, well, this little group, it was successful. So if you look at the proper trial, very well-designed trial, great trial, practice-changing trial. Well, practice has changed based on a secondary endpoint in sort of changing mortality in patients who were bleeding, and not their initial primary endpoint. And yet that's been practice changing. That's not to say that to adopt that practice is wrong, but we make a lot of changes based on results that are not potentially as robust as they could be.
Yeah, you just mentioned a few different ones now, but should we be using different outcomes, such as composite outcomes, in critical care research, or should we buy into this push to report quality-adjusted life years?
So within the critical care world, I mean, that's an area of debate. Quality-adjusted life years, it's a hard one to kind of wrap your head around. I understand the value of it, but even that, it smacks of, actuarialism or something like that. It's a tough one. There are things that people use, which is like days alive and off the ventilator, and that's a composite outcome. And for those things, you need to set a time point. So it'd be like, in the course of 28 days or something like that. I think that's not a bad outcome if you're looking at, ARDS and things of that nature. But again, that's a composite. And the one thing you have to be careful about with composite endpoints is that there are components, right? So say alive and free of ventilation. So there's a mortality component to that, and there's a ventilator dependent component of that. And you can have patients who die but wouldn't need the vent, or conversely, you can have patients who are survive but they're on the vent for 28 days, and you can, in their ventilator-free days could be the same, but those are kind of different outcomes. And so frequently in composite trials, or frequently, they should demonstrate what are the various components. And so if there's a big skew in that between the two groups, the treatment and control groups, that's something that needs to be looked at. There's also other patient-centered things like, functional mobility and healthcare quality of life. Nothing has really gained traction. I think the advantage to critical care is that, okay, well, we can say that we're dealing with patients' lives, and therefore mortality is something that we should use. I don't know. I like it's an unsatisfactory answer, but I don't know. As many problems as there are with mortality, I haven't yet sort of seen, oh yeah, no, but this is what we should use to replace it.
Yeah, but can't these composite endpoints of quality-adjusted life years help you with patient and family discussions? I mean, for example, if you survive Mr. Smith, you're going to have these limitations going forward. I mean, there's probably some importance with looking at them in addition to mortality, right?
Oh, I think those things are hugely important, but I think it's hard to design a trial around them, because then mortality always sneaks in. There's always the competing risk of death. So if we're talking about if our endpoint is something like quality of life, well, how do you actually score a death in that? And so that's a challenge. I mean, there's a couple of good papers about that, yes, we'd like to move away from mortality, but our population is at higher risk of death than others. So that's a challenge.
Yeah, one last thing that I've heard you talk about previously, and I find particularly interesting, and I'd suspect that a lot of the audience really doesn't know a lot about. Could you tell us what exactly is the fragility index?
Yeah, so the fragility index is a number which quantifies how many patients you would have to move from one group to the other, so having an event to a non-event, for the trial to fall out of its statistical significance. So, deaths in the control group or the treatment group change from a non-death, and your p-value then winds up being above 0.05 or whatever you set it at. So it's not a way to kind of gauge your statistical significance, but it's a way to gauge how robust those findings are. I think what's important is that the p-value of 0.05, there's nothing magical about it. It's just kind of convention of what we use, right? And 0.05 means that 1 time out of 20, these results that we find could be due to random chance. The fragility index helps us look at how close we are. I mean, and anybody who's done any kind of research, bench research, whatever, at some point in the middle of the night, you're sitting with your notebook and you're crunching those numbers. And you're like, oh, if this one had just gone over to that group, we would have hit that. We would have gone under 0.05. Well, the fragility index is a way to quantify that. So in a paper published a couple of years ago, looking at critical care trials, most of these trials, a preponderance of these trials had a fragility index of 0 to 1, meaning that a lot of these trials that did in fact achieve statistical significance only relied on a small number of events.
Yeah, so just to be clear, the trials didn't actually report the fragility index. The paper went back and calculated it.
Yeah, right. So one of the things, there's a good paper in JAMA Surgery that was published, I think, a year ago, where they looked at surgery trials, and because people have begun to look at the literature in their respective fields, and in medicine and critical care, there's a lot of the fragility index is relatively low. Well, in surgery trials, it's also quite low, and so a lot of people are making the argument that in a published clinical trial, one should publish the fragility index to let the reader know that one or two patients could have gone either way, and therefore you got to be a little more skeptical. Because I think at the end of the day, we have to be skeptical readers. We have to be critical readers. We don't want to just jump down to the conclusions and say, okay, that's that. One of the points about the fragility index is if your number of patients excluded or lost to follow-up is greater than your fragility index, if you don't know what happened to those people. So you look at the CRASH-2 trial. CRASH-2 trial has a fragility index of 51, which is great, except the CRASH-2 trial is like 20,000 patients. They had 84 patients lost to follow-up. So, it had some of those patients gone in a different direction, would that be different? In the work that I've done looking at trials in trauma, the fragility index of the 5 trials that show mortality benefit, the fragility index is 0 or 1 in 3 of them. And then you've got the CRASH-2 trial, and then there's another one where it's 5. So the fragility index doesn't replace the p-value, but it gives you a guide as a reader for how robust the results are. The other last thing I'd say about it is there is a famous, paper by John Ioannidis, I think is his name, why do most randomized controlled trial, why the results are false. And one of the reasons is that as we kind of touched upon earlier, when you're looking at control event rate and treatment effect, you by necessity have to pull those numbers from previous trials, previous small single center pilot trials, whatever. And Ioannidis writes that part of the problem is when you take those trials and then you expand them into larger studies, you then unmask a lot of the fact that, well, maybe your initial result was closer to random chance, or you introduce more heterogeneity into your second study population or things like that. So I think that the fragility index helps you be a little bit more of a critical reader. One other thing I'd like to say is, one of the criticisms of this sort of work and discussion about, is the treatment effect overestimated? Is the control event rate overestimated? Lots of people, when I've talked about this in the past, have said, and you see this in the literature too, well, just make the trials bigger. And setting aside the problems of, resource use and trials that are bigger, take longer to accrue, which is not a small problem. I mean, a big part of failure of early termination of trials is failure to adequately accrue patients in a timely fashion. But if you increase the size of a trial, you almost always have to relax your inclusion criteria somewhat. And by doing that, you may increase your heterogeneity. So your patient population is going to be different. But, we go back to the discussion earlier about what's the risk profile within our patient population. If you relax your criteria, you may have more patients who are lower risk. So that then, it's not just the number. You've increased the numbers, but you probably actually you've improved your number of patients, but you may not actually improve your number of events, or you've decreased your ability to discriminate a difference between your treatment group and your control group.
Yeah, I think that's a very important point. Just lastly, before we finish up, inquiring minds want to know, Dr. Benoit, if you're going to design a trial tomorrow and you have no pressure from regulatory agencies, are you going to use mortality as one of your primary outcomes, or are you going to use composite outcomes?
So, if I'm doing something in the ICU, for example, I think I would use mortality, but I think that there's a middle ground there in the future, in the not too distant future, of kind of the targeted therapy, right? But also the targeted patient population. The randomized controlled trial is still the gold standard, but there are a lot of interesting trial design things, trying to get away from this sort of coarse metric. And so I don't know that the endpoint is bad, but I think how we select the patients is probably something that we can improve on. I'm the local PI for a randomized controlled trial in ventilator-associated pneumonia here. It's a multinational, multi-center trial, and we're one of the first centers in the U.S. to enroll patients. And the endpoint is clinical resolution of ventilator-associated pneumonia, which is, I won't say it's a squishy endpoint, but it's not a great one. And so I read through the protocol, and then wanted to call up the designers. Well, they're like years down the road into this, but it was the exact same stuff. Boy, this endpoint is not bad, but boy, you're expecting this kind of a treatment effect, and so I'm just loading the trucks here, but I think the design phase, like this, you see these same, I hesitate to call them errors, but you see these same things happening over and over again. It's not just in surgery; it happens all over the place. And I think one of the things that it's taught me in reading all this is that you have to be a skeptical reader. You have to be prepared, and you can't just read the bottom line.
Awesome. This has really been a great discussion. I just want to say thank you again for taking the time to discuss this topic. It's an important topic, and frankly, I don't think we speak enough about it. And I think students, residents, and faculty will get a lot out of this discussion. So thank you for joining us here today, Dr. Benoit.
All right. Thanks a lot, Ken. And let me know when we can do this again on something more interesting or illuminating.
Oh, I'll hold you to it.
Sounds good.
This concludes this week's episode of the Brown Surgical Podcast. I hope you have enjoyed the last few episodes where our focus has been on the research theme. We've covered a lot of ground discussing the role of the surgical scientist with Drs. Dahi Heffernan and Sean Monahan, and concluding with today's episode on outcomes in clinical research with Dr. Eric Benoit. Next week, we're excited to kick off our Chief Surgical Podcast with Dr. Paulina Chmielewski, who is going to talk to us about her effort this year in bringing the topic of narrative surgery to our wellness curriculum. Stay tuned for that and other upcoming discussions with our chiefs on crushing compartment syndrome, esophageal perforation, and management of patients undergoing a HIPEC. Have a great week, and I'm looking forward to having you back with us in the next episode.